So in the previous general surgery module, we discussed the patient journey from the ward till the theatre, and we ended that module with the OT positioning. That means the patient is anesthetized and positioned on the table. Now, when the surgeon has to start the surgery, the surgeon requires a blade to make an incision, and that is what we are going to start this module with. So surgical blades are of various types, and they're given a number, right? So you can have a number 10 blade, a number 11, a number 12 blade. You can have 15, 20, 21, 22, 23. Those are the blades which are available to us when we have to carry out a surgery. Now, let's talk about some unique features of these blades which have also been asked in the exam. Number 11 blade has been asked a lot of time, and number 11, you can see that this is a pointed blade. So number 11 is a pointed blade. This is also known as a stab blade. It is known as a stab blade, and this is used in patients when we have to carry out an incision and drainage. Where do we do incision and drainage? When there is an abscess, when there is pus, that's where we do an incision and drainage. Also used when an arteriotomy has to be done, that means an incision has to be made in the artery. We use a number 11 blade. Number 12 has also been asked in the exam. Number 12 is a curved blade, and when you have a curved blade like number 12, this can be used for suture removal. So this is what I will use if I have to carry out a suture removal. The other blades, that is number 10, 15, 20, 21, 22 and 23, they all have a belly. They are curved, right? This curved portion of these blades is known as the belly of the blade. And all these blades, that means 10, 15, 20, 21, 22, 23, are all used for making incisions, right? They're all used for making incisions. So that is what you need to remember. And another point which I want you to remember, that the belly of the blade is the sharpest portion of the blade. The belly of the blade is the sharpest portion of the blade. It is not the tip, it is the belly of the blade which is the sharpest portion of the blade. Now, a blade is always mounted on a BP handle. This is a barred Parker handle, which is frequently asked in the Viva in final years and also sometimes as an MCQ. Now, this you can see is a barred Parker handle, and we mount the blade on a BP handle, and the correct way to hold this. So an examiner will ask you, how will you hold this? So you hold it like a pen. You hold it like a pen, right? Or another technique is to palm it, where you can hide it in your palm. That is another technique. But the more common technique is to hold it like a pen. Now, there are certain things which I want you to remember, which are very important from the MCQ point of view. I told you in the previous module also that patient safety and surgeon and staff safety is of utmost importance these days, and a lot of questions are being asked around these points. So you should know that whenever you mount a blade, the blade should always be passed in a kidney tray. It should be passed in a kidney tray to avoid a sharp injury. And I will show this to you. I will show videos to highlight all these points. I'm just writing them down, and then I will give a practical demonstration so that you can remember it easily. Now, just in case a kidney tray is not available, then whenever you are passing the blade, you should always pass the blade with the pointed end towards you. Right? So if the nurse has to pass me a blade, the nurse will pass it with the pointed end towards herself so that I don't get hurt with it. Right? So always remember, best is kidney tray, but if you have to pass it, always the pointed end should be towards you. Even if the person whom you're passing it to is your enemy, still the pointed end should be towards you. Those are basic surgical etiquettes. Now, when I have to make an incision, and this is the next thing which I want you to know, a surgeon is an artist, right? And we always make an incision. Like a painter makes his masterpiece, similarly we make an incision. We never give an incision. And you have a lot of old-timer faculties in surgery who are very particular about this point, that you say that we always make an incision. Now, to make an incision, the blade should be perpendicular to the skin. Blade should be perpendicular to the skin. Otherwise, it can give rise to, otherwise there can be undermined edges, and we don't want that. Otherwise, we can land up with undermined or beveled edges. Okay. There are certain other things which I want you to know. When we are making an incision, the surgeon goes from far to near, or from the opposite side to same side, or from the opposite side to same side. What does this mean? So supposing I have a blade here, this is the BP handle and I have a blade, and you know that I am left-handed. I'm the left-handed surgeon, right? So if I'm left-handed, when I have to make an incision, I will go from my right to my left, right? I will go from my right to my left, not from my left to right. That is going to be very awkward. So from my right to my left, or from far to near. From far to near. So that is what I want you to remember. These are basic points when you are handed a blade and when you make an incision. Now, to just reinforce these facts, let me show you some videos. So in this video, you can see that the nurse is mounting the blade on the BP handle. Now, we never handle it with our hands because we can get a cut. So you always use a mosquito to hold the blade and then to mount it on the BP handle. In this video, you can see that the nurse is handing me the blade, and I told you it is always handed in a kidney tray so that I don't get an injury. Once I have the BP handle in my hand, I'm going to make an incision. And you can see here that I'm the left-handed surgeon and this is my right and this is my left. So when I make the incision, I'm going to go from my right to my left. So I'm putting my blade is perpendicular to the skin, and I'm going to go from my right to my left. Now you can see I have the number 11 blade in my hand, which is a pointed blade which is used for incision and drainage. And this was a lady with a breast abscess. Now at the point of maximum tenderness or fluctuation, I'm going to just make a stab incision there. So I just stab that area, and you can see once I do that, then first some blood comes out and then you can see that pus has started coming out. So this is used for incision and drainage or arteriotomies. Now there are certain other things also which we need to keep in mind when we are making an incision over a patient. The other points are that incision should always be made parallel to the skin tension lines or the Langer's lines. This has also been asked in the exam. And these Langer's lines, they represent the orientation of the dermal collagen fibers. And it has been seen that any incision which is made parallel to them, it heals better. Incisions made parallel to them heal better. Whereas incisions made perpendicular to them, if you make it at right angles, then they're going to give rise to an ugly scar. So one should be cognizant of the Langer's lines while making incisions. So you can see in this image, you can see the distribution of the Langer's lines over the body. And this knowledge should be there with the surgeon so that we give rise to a better scar. The other thing which one should be concerned about is anatomical structures, right? So supposing I'm making an incision over the parotid. Now I know in the parotid, the facial nerve is running here. So I have to be careful that I don't make an incision which is so deep or so close to the facial nerve that it injures it. So an idea of the anatomical structures is also very important. Cosmetic factors I've already discussed with you, and an incision should give you adequate access to carry out the surgery for which you're making the incision. So these are the points. Also, I've told you that avoid undermined edges. We should always remain perpendicular to the skin. Now, once we make an incision, invariably in the videos which I've shown you, you've seen that there is bleeding. So once there is bleeding, we have to control that bleeding, and that is where comes the role of energy sources. So that's the next topic which we are going to talk about. We will talk about energy sources, and the most commonly used energy source is cautery. electrocautery, or cautery is the most commonly used energy source, and there are two types of cauteries which you should know about. Both these images have been asked multiple times in the exam. This one here is a monopolar cautery. This monopolar cautery looks like a pencil. You can see, you must have seen when you'd gone to the OT, you must have seen a surgeon holding a pencil-like thing. That is the monopolar cautery. And the one which looks like prongs, that is a bipolar cautery. This one is a bipolar cautery and it looks like prongs. Now, what are the differences between monopolar cautery and bipolar cautery? How is the functioning different? Let's discuss about that. So, let's first discuss about a monopolar cautery. Now, monopolar cautery, you can see in this image that this pencil-like thing has two buttons. It has a yellow button and it has a blue button. So, this yellow button, if the surgeon presses the yellow button, or you must have seen a yellow foot paddle, right? If you've gone to the theater, you must have seen that there's a foot paddle which has a yellow button and a blue button. So, if the surgeon presses the yellow one, then cutting of the tissue occurs. Whereas if the surgeon presses the blue one, then coagulation occurs. We'll talk more about this, but first I want you to understand the principle regarding how a monopolar cautery works. So, monopolar cautery, there is a cautery machine which is there, and this cautery machine is going to produce current. This cautery machine is going to produce current. Now, this current comes to the cautery pencil or the cautery tip. This is the cautery pencil, also known as the Bovie tip. Bovie was the person who invented cautery. So, this cautery tip is also known as the Bovie tip. Now, the surgeon is going to use this current and place it on the body and would either carry out cutting or coagulation. So, would either cut or coagulate, and with this the current enters the body. Current enters the body. Right, so when the current enters the body, that is when cutting or coagulation will happen. Now, once the current has entered the body, the current also has to escape the body, right? So, for that to escape, you must have seen that a cautery pad is put. A cautery pad is put. So, you must have seen in a surgical patient on the thigh or the calf, of that patient, the technician puts a white pad, a cautery pad, right? And what is the function of this cautery pad? This cautery pad, you can see that this cautery pad which is put, this is where the current is going to go out from. So, all the current comes to this cautery pad and then again goes back into the machine, and that is how the circuit is completed, right? So, one electrode is your cautery tip and the other one is the cautery pad from which the current is going to escape out, and this is how the circuit will get completed. Now, there are certain points regarding the cautery pad which I want you to know. The first thing which I want you to know regarding cautery pad, that cautery pad should have a large area of contact. It should be placed over a well vascularized area. And a cautery pad should ideally be placed over a field which has less hair so that it can stick properly, right? So, these are some points which one should be mindful of while placing the cautery pad. Now, there are certain scenarios which happen in the OT which I want to discuss, and they've also been asked as MCQs. The first scenario is that technician fails to attach cautery pad. So, if the technician fails to attach the cautery pad, the circuit will not get completed, right? I just told you for the circuit to get completed, you need a cautery pad. So, cautery will not work. And you will see an angry surgeon shouting at the technician to attach the cautery pad so that the surgeon can start working. The second scenario is that a small cautery pad is placed. A small cautery pad is placed, or only small area of contact is there. Only a small area of contact is there, right? So now what is going to happen? All the current which was earlier going through a big pad is now going to go through a small area, right? Is now going to go through a small area. And when it goes through a smaller area, heat is generated here. And when heat is generated, this can give rise to burns at the site of the cautery pad. So increase heat, and this will give rise to burns at the site of the cautery pad. This has also been asked in the exam. Burns at the site of cautery pad, right? So these were the points regarding cautery pads. Now, in a monopolar cautery, I have just told you that the current is traveling through the body, right? So supposing I am cutting in the arm, the current will travel through the body and will exit out through the thigh where the cautery pad is. So the current is moving through the body, right? So because there is spread of the current, because there is spread of current through the body, right, this can interfere with cardiac conduction. This can interfere with cardiac conduction. So I want you to notice one thing. Sometimes when you go to the theatre, sometimes when the surgeon is using the cautery, you will see that the ECG readings go haywire, right? That is because of the cautery current traveling through the body. Now, in a normal person, this is not a problem. But patients with cardiac pacemakers, it can interfere with the conduction. It can interfere with conduction. So, in a patient with a cardiac pacemaker, monopolar cautery is avoided. Monopolar is avoided so that there is no abnormality in the conduction, or pacemaker mode needs to be changed. Pacemaker mode needs to be changed, right? So what happens is that sometimes these pacemakers, why is a pacemaker put? Because if there is an abnormal rhythm, then this pacemaker will send out a shock wave to convert it into a sinus rhythm, right? Now, if you use a monopolar cautery, there's going to be abnormal rhythm, and the pacemaker will sense as if the heart is not beating properly. So it'll constantly keep on shocking the heart, and you don't want that, right? So that is why we either avoid monopolar cautery in patients with pacemakers, or we have to change the mode of the pacemaker before using the monopolar cautery. The fourth point which I want you to know is that if there is a pedicle, or a narrow base, if there's a pedicle or a narrow base, then there is something known as channeling of current. Channeling of current. What channeling of current basically means is that supposing there is this pedicle which is here, right? This pedicle which is here, and if you apply cautery at the tip, then all the current will also get channeled to the base. When there is a narrow pedicle, the current gets channeled to the base, and the base also gets burnt. The base also gets burnt. So what is the significance here? The significance is, supposing penile surgery, if penile surgery or circumcision is being carried out, and you apply cautery at the tip of the penis, it can also cause burns at the base of the penis, right? So that is why in penile surgeries, or when there are end arteries, we avoid monopolar cauteries. We avoid monopolar cautery because of channeling, because it can even burn the base, and that can be detrimental for the patient. Okay. And the fifth point which I want you to remember, that there is also lateral spread of the current. There is lateral spread of the current in monopolar cautery, because when you apply it, the current travels through the body, and this can cause thermal damage to nearby vital structures. This can cause thermal damage to vital nerves and vessels. So in those areas where you have vital nerves and vessels, there also we will avoid monopolar cautery. And what are these surgeries? These surgeries are thyroid surgeries. You have the recurrent laryngeal nerve, the external laryngeal nerve. This is when we are dissecting the axilla. You have the long thoracic nerve, the thoracodorsal nerve. CNS surgeries, you have a lot of important vital nerves in CNS surgeries. So these are the places where we avoid monopolar cautery, right? So to summarize again, monopolar cautery will be avoided in thyroid surgery, parotid surgery, axillary surgery, CNS surgery, and in patients with cardiac pacemakers. And also ear lobule and penile surgery where there are end arteries. So in all these places, because monopolar is avoided, we will use a bipolar cautery. So these were the points regarding monopolar cautery which I wanted you to know. Now in a monopolar cautery, I showed you that there can either be cutting or coagulation, right? Two things can happen. So you should also know the waveform, because this has also been asked in the exam. Now the cutting current, we generate sufficient heat to cause cell water to explode into steam, and that is what causes cutting. Whereas in coagulation, cell death is caused by dehydration and protein denaturation. Right? Protein denaturation. We never apply coagulation to the skin. Because if you apply coagulation to the skin will get burnt, right? So no coagulation to the skin. Please remember that point as well. Now the cutting mode, I want you to see here, in the cutting mode, there is a continuous current. So low voltage, there is low voltage continuous current. That is what leads to cutting. Whereas in the coagulation mode, there is high voltage alternating current, right? So there is high voltage alternating current. So there are gaps in between, and there is high voltage in coagulation, right? So you can see the waveforms here. Cutting is continuous, coagulation is high voltage alternating current. Another type of coagulation, so one more type of coagulation is called fulguration. And in fulguration mode, you can see that the voltage is even higher than coagulation. In fulguration, the voltage is even higher than coagulation. And you can even have a blend mode. Blend mode means it is a combination of cutting plus coagulation. So in this waveform, there is cutting also and coagulation also which is happening. But if you have to use it on the skin, you will use the cutting mode. So these were the points regarding monopolar cautery which I wanted you to know. Now let me quickly show you a video of monopolar cautery and then we move on to bipolar cautery. So you can see this is the monopolar cautery. It looks like a pencil and there is a yellow button and a blue button. And if I press the yellow button, then cutting is going to happen. And if I press the blue button, then coagulation will happen. So you will see here, now I'm going to use the yellow button to increase the incision. So here I'm using the yellow button and I'm going to cut the subcutaneous tissue with the yellow. After pressing the yellow button, that is the cutting current. Now once I do that, and if there is bleeding, then I can press the blue button and I can stop the bleeding. Now one more way to stop the bleeding is that I can use a forceps to pick up the vessel, and the nurse can touch my forceps. And even by doing that, the vessel will get coagulated, right? So there are two ways. Either you directly press it on the vessel, or you can hold the vessel with the forceps and then you can touch the forceps with the coagulating current. Now moving on to bipolar cautery. Bipolar cautery, I told you they are like prongs, right? They are like prongs. So there are two blades. It is like prongs, one blade and the other blade. And in bipolar cautery, what happens is that current comes from one blade and it goes back through the other blade. So these are two electrodes basically, and current is coming from one electrode going back through the other electrode, and that is how the circuit is getting completed. Now you understand that the circuit is getting completed locally only, right? It comes from one blade, goes back to the other blade. So do I need a cautery pad like I did in a monopolar cautery? No, because one blade current will come, the other one acts as a pad and it takes back the current. So the advantage, no cautery pad is required. No cautery pad is required in a bipolar cautery. Okay, so that is one big advantage. You don't need that. And bipolar cautery, there is no lateral spread of current, right? There is no lateral spread of current like in monopolar cautery. So this is going to be safe in all the places where monopolar cautery was avoided. That means close to vital structures, end arteries, and in patients with pacemakers. Now, one of the problems with a bipolar cautery is that bipolar cautery will only carry out coagulation. You cannot cut using a bipolar cautery, so it will only coagulate. So these were the points regarding bipolar cautery which I wanted you to know, and I'll quickly show you a video of bipolar cautery being used so that you understand the difference between the two. So you can see this is the bipolar cautery in my hand, and I'm just using it over a gauze piece, not over the tissue, just to demonstrate that when I get the two prongs close to each other, then it'll cause coagulation in that area. So current will come through one prong and it will go back through the other prong. So that was regarding monopolar cautery and bipolar cautery. But these are not the only energy sources. In fact, a lot of development has been made in the field of energy sources, and lots of energy sources are available which we'll discuss. But before I do that, one very important question which has been asked multiple times in the exam, that cautery sources are the most common cause of OT related fires. This question has been asked. This is written in Bailey and the latest edition of Sebastian as well. So one has to be careful while using these cauteries because they can sometimes cause a lot of problems as well. Moving on to the other energy sources, one more energy source is ligashore. Now ligashore is an energy source which uses heat plus pressure to carry out coagulation. Right? It uses heat plus pressure to carry out coagulation, and ligashore can coagulate vessels up to 7 millimeters in diameter. It can coagulate vessels up to 7 millimeters in diameter. Now, it uses the body's collagen and elastin to seal and divide. So what basically it does that there are two prongs. So it is like there are two prongs. One blade is here, another blade is here. And if this is the vessel, we'll apply it on the vessel and then we press a button. Now when we press this button, because of heat and pressure, the proteins get denatured and coagulation occurs, right? The collagen elastin gets denatured and coagulation will occur. Now the advantage is that there is a feedback mechanism. So that means that energy delivery is in a precise manner and it results in automatic discontinuation when the seal has occurred. What does this mean? Vessel, the two blades of ligashore, I press the vessel, I press the button, it will cause coagulation. So what does that mean? That means these are the two blades of the ligashore. This is the vessel. When I press the vessel, I press a button, then coagulation will occur. Once the vessel is sealed, there will be a sound which will come out, right? A teeny sound which will come out that will tell me that the vessel is now sealed. And once I know the vessel has been sealed, then I can cut it. So the advantage of ligashore is that there will be discontinuation of energy once the vessel is sealed, and then vessel can be cut. Then the vessel can be cut. And second generation ligashores, there can be cutting there can be coagulation. First it will coagulate, followed by cutting. Right? So that is regarding ligashore. Now another energy source from which lots of questions have been asked is a harmonic scalpel. Now harmonic scalpel, this works on the ultrasonic principle. So what is the ultrasonic principle? This has an oscillatory blade. Which oscillates between 20,000 to 50,000 hertz. So this blade oscillates between 20,000 to 50,000 hertz, so rapidly it oscillates. And because of this oscillatory movement, it causes protein denaturation. And this leads to coagulation. But what is the peculiarity about this coagulation? And that is the beauty of harmonic scalpel, that this coagulation occurs without heat production. Now, what is the advantage if it occurs without heat production? The advantage is that it can be used close to vital structures. Because heat is not getting generated. It has a very precise cut. It can cut through scar tissue also. And this can also seal vessels which are 7 millimeters in diameter. One of the drawbacks of harmonic over ligashore is that it takes longer time. In harmonic as compared to ligashore. Slightly longer time in harmonic scalpel to seal and cut as compared to ligashore. That is the only minor drawback with harmonic scalpel. Otherwise, there are more advantages as compared to a ligashore. Now, because both of them, there are certain advantages and disadvantages, there is another instrument that is known as Thunderbeat S, and this is mentioned in the latest Bailey as well. This is Thunderbeat S, and this Thunderbeat S has features of both harmonic and ligashore. It has features of both harmonic and ligashore. So the surgeon can choose. There is a button to switch between the ligashore mode and the harmonic mode, and the surgeon can switch at will and utilize the peculiarities of both the instruments. So this is another term which you should know for the exam, although it's not been asked till yet. So another very interesting equipment is called CUSA. CUSA is cavity ultrasonic aspirator. And this is particularly used for liver resections. Now, in the module on liver tumors, I've shown a video of liver resection which was shared by a friend who's a hepatobiliary surgeon, and he's used CUSA to carry out the resection, and you can always see that module and see how liver resection is done. Now, CUSA works on the principle that hepatocytes are particularly susceptible to oscillatory fragmentation oscillatory fragmentation due to high water content, right? Due to high water content and low collagen. So that is the beauty of CUSA, that it will act well on those tissue which has high water content, low collagen, and it can fragment the tissue and also seal up the vessels while doing this. Also, because it is an aspirator, it can also aspirate the gas which is produced. It can suck it out at the same time. So it is particularly useful for liver resections, and that too, if somebody asks you cirrhotic liver or non-cirrhotic liver, it will be better in a non-cirrhotic liver. It will be better in a non-cirrhotic liver. So these were the energy sources which I wanted you to know, which have been mentioned in Bailey. Now, the latest edition of Sebastian also mentions some other energy sources which are high yield, especially if you're preparing for the INI CET exam or the super specialty exam. You should know about these energy sources as well. And these are radio frequency ablation and microwave ablation. So radio frequency ablation, it is high frequency ablation and high frequency alternating current. So it is like coagulating current, which we've already discussed. Now, because it is similar to electrocautery, you need a grounding pad. You need a cautery pad. And radiofrequency ablation has been used for tumors up till 3 centimeters in size. Again, when we talk about liver cancer, hepatocellular cancer, their radiofrequency ablation can be used for tumors up till 3 centimeters in size. It can ablate that tumor. In comparison to this, microwave ablation, microwaves are in between infrared and radio waves, and this works on the principle of oscillation and frictional heat, right? So this works on the principle of oscillation, and this can oscillate, or this can cause destruction in a larger area and in a more homogeneous pattern, right? And less time required than radiofrequency ablation. That is why this is being preferred over radiofrequency ablation in a lot of centers these days, because it can carry out more homogeneous destruction over a larger area, less time is required, and no grounding pad is required in microwave ablation. The final one which I want you to know is argon beam photocoagulation, APC. APC is argon beam photocoagulation. So here a beam of argon gas is used to carry out coagulation. It has rapid activity, but one of the disadvantages is shallow penetration. Now, it is an advantage at certain areas and it is a disadvantage at certain areas. So, APC, this can be used in patients where there is upper GI hemorrhage or there is Barrett's esophagus. In those areas, you can use argon photocoagulation. Also, another area where you can, so this can be used in places of Barrett's esophagus, where you know that there is metaplasia, GAVE, that is gastric antral vascular ectasia. This has been covered in the upper GI hemorrhage module. So in these places where I don't want a lot of penetration, otherwise there will be a perforation, there we can use argon photocoagulation. There is faster heat dispensation, there is less eschar formation, but it is ineffective when there are larger vessels. So it can only be used when there are smaller vessels. It cannot be used when there are larger vessels. In fact, it should be avoided. It should be avoided close to central veins because it can give rise to embolism as well. It can give rise to embolism because this argon gas does not dissolve. So if you use it close to a central vein, this argon gas can go and cause an embolism as well. So these were the extra edge things which I wanted you to know from the latest Sebastian, useful for the INI CET and the SS exams. Now, before I end this module, I want to tell what are the points which are important for final year students, like I've been doing in all modules. What can be asked in the theory exam from this module? So a short note can be asked on cautery. A short note on cautery has been asked in a lot of university exams. So that is what you should know about. I've already highlighted the important points, the MCQs which have been asked. And to end this module, let's just quickly do some MCQs and then we'll end this module. So, true and false regarding surgical blades. Number 11 blade is known as a stab blade and is used for incision and drainage. This is true. Belly of the blade is the sharpest portion of the blade. This is also true. A right-handed surgeon, while making an incision, should go from his right to his left. I told you this will be very awkward. So you always go from opposite to same side. So from the right-handed surgeon should go from left to right. This is false. Or should go from far to near. Surgical blade should ideally be passed in a kidney tray during surgery. This is true. I showed you the video as well. Number 10 blades are used for suture removal. This is false. This is number 12 blade. Right. Which of the following is not true in a patient with a cardiac pacemaker undergoing surgery? Monopolar cautery should be avoided in such patients. This is true. This we've discussed because it can interfere with conduction. Bipolar cautery is preferred. This is also true. I've told you because it will not interfere with cardiac conduction. Cardioversion and overpace modes should be turned off. This is true. I told you otherwise constant shocking of the heart will keep on happening. So you can change the mode of the pacemaker and then one can use a monopolar cautery as well. And elective surgical procedures take priority over correction of symptomatic heart blocks. This is false. This is a direct line out of Sebastian. You should know that symptomatic heart blocks should first be corrected and then elective surgery should be done. So first correct symptomatic heart blocks. Cutting and coagulation can be done using monopolar cautery. This is true. Bipolar cautery can function without a cautery pad. This we've discussed. This is also true. An improperly placed small cautery pad can give rise to burns at the site of attachment. This is also true. Monopolar cautery is safe close to vital nerves. False. We use bipolar. Ligashore can seal vessels up to 7 millimeters in diameter. This is true. Harmonic scalpel can cause coagulation along with heat production. This is false. It does not cause heat production. That is the advantage. Thunderbeat S is a device which has features of both ligashore and harmonic scalpel. This is true. And coagulating current is low voltage continuous current. This is false. Coagulation is high voltage alternating current. This is the description of cutting current. So these were some questions which basically summarize everything I've discussed in this module. This module is important from the point of view of the MCQ exam, and especially if next is implemented with the number of questions increasing, you can definitely expect 1 to 2 questions from this module. Thank you.